I want to welcome all of you to this Global Genes webinar on precision medicine and rare disease. I'm Daniel Levine, host of Global Genes Rarecast and editor of Rare Daily, and it's my pleasure to be moderating today's panel. We've got a great group of panelists today who are at the front lines of precision medicine. Our panelists are Dawn Laney, assistant professor and genetic counselor at the Emory School of Medicine, Robert Hopkin, associate professor of clinical pediatrics of the Cincinnati Children's Hospital Medical Center, and Torsten Haferlock of the Munich Leukemia Laboratory. Thank you all for joining us today. I'd also like to thank today's sponsors, Amicus Therapeutics and Daiichi Sankyo, for their support of today's webinar, and the staff of Global Genes and Ashley Yee for her work putting together and coordinating today's program. This webinar is meant to be interactive. I encourage people listening in to use the instant messenger in the bottom right-hand corner of their screens to send questions for the panel as we go. I'll do my best to work these questions into our conversation. We'll also save time at the end for questions from the audience. Today we're discussing precision medicine, what it is, why it matters, and how it's reshaping how physicians treat patients with a rare condition. We're going to start with an overview on precision medicine and rare disease and then move to two case studies to see this approach in action. If you've got questions for our panelists today, don't forget the lower right-hand corner, just instant message them to me. With that, I'm going to turn it over to Dawn Laney, who's going to explain precision medicine, what it means in the context of rare disease, and what it'll take to make it standard practice in treating rare disease patients. With that, let me turn it over to Dawn.
Good morning. This is Dawn Laney, and as was mentioned by Danny, I am a genetic counselor at Emory University, and I'm also an assistant professor within that. So I'm very excited to have this time to talk with you a little bit about precision medicine in rare diseases and how specifically it applies to the rare disease space. Next slide, please. These are my disclosures. As you can see, I work with many of the companies, and I also work with a startup of my own. Next slide, please. What I'm going to work on as we go through this agenda is really trying to make sure we're on the same page in how we understand precision medicine and the role of precision medicine with genetics and rare diseases. Next slide, please. When I think about precision medicine, I think about these rare disease zebras, which is how we think about rare diseases. That when people hear hoofbeats, when physicians hear hoofbeats, they're supposed to think about horses. But in our world, in rare diseases, we think about zebras. And precision medicine is almost a way to figure out that there's a lot less horses out there than zebras. The specific goal of precision medicine is to figure out what treatment and dose is going to be most effective for a group of individuals based on all the things that make them them and the diseases they have that impact that. Next slide, please. One of the things that we really think about when we're talking about precision medicine is how is that different from personalized medicine? Because sometimes these terms are used interchangeably, but these diagrams help you figure out what the difference is. When we think about personalized medicines, most people think, maybe that means that the preventions, treatment, and monitoring schedule is just for me. It's just an individualized treatment plan, which is sort of how a good primary care physician would work towards anybody who's got some chronic health conditions or just preventative medicine. Precision medicine is more about trying to find some changes in genes that help a specific group of people be better treated and have better management and monitoring. So think about precision medicine is trying to find groups of people who can be treated similarly with better outcomes versus personalized as being more individualized therapy. Next slide, please. And really the true goal of precision medicine is to find the right drug at the right dose at the right time to bring to the most effective outcome. Next slide, please. One huge piece of precision medicine relates to genetics. And in order to understand how that relates, you've got to think about genetics and the different tests that are available in genetics at this time. If you think about the genome, that's a complete set of instructions on how to make your body, how to maintain your body, and it's like having a big recipe or instruction book. When you hear about someone getting their genome tested, they're looking at that whole big picture. If we're looking at a smaller piece of that, if you think of the genome as being a giant apple, An exome is just the portions of the genome that specifically code for genes that we fully understand. So if you took a slice out of that apple, a very important slice, then you would have an exome. So genome being the larger picture, the exome being a smaller picture, and then you can do specific gene testing too. Think about that like taking the seeds out of the apple and just testing one or two of those. So when you use genetics and precision medicine, they use those kind of tools to look either for a broad spectrum of changes that might apply to how treatment affects you or how a condition may affect you, all the way down to looking at just one specific change in one specific gene. And that works in the whole body when we're looking at rare conditions that affect the whole body, or if you're looking at the genome of a tumor, you can do that as well. A tumor genome is going to be different than a whole body or what we call constitutional genome. But in both cases, we can genetic test for both things. And in that way, we're able to learn a little bit better about somebody who might respond better to treatment or be put in a group that tells us more about the treatment. Next slide, please. So when you think about this gene change, what we're really doing when we do genetic testing is reading through that whole instruction book and looking for misspellings. The funny thing is that some misspellings don't cause any problems. Some misspellings within our genome, exome, or genes are normal and don't provide us much good information. But when these are being interpreted, they need good clinical information or symptoms about health problems or symptoms about different parts of their background that really can help someone look at the gene misspellings or changes or variants and find out if these have any true impact on treatment or how the disease impacts someone. So these are the kind of questions people ask when they're trying to interpret their genetic testing. Did we get enough information about what's going on with that person's health to really understand which gene changes might be important or less important? Are there other relatives that have that same gene change and have the same symptoms or effectively react the same way to a treatment? Or is there, when we find these changes, what's out there? What have scientists already learned about these gene changes? All of these things are put together to help us understand genetics at one point in time. And it's really important to understand that we're learning more and more about each of these gene changes every day. So if you get your exome done once, your genome done once, they can use that same data and look at it again, just do a different interpretation 1 year from now, 5 years from now. You don't need to test again. You just need that new information to be integrated with that interpretation to understand better what's going on with you. Next slide, please. When we think about what precision medicine actually means, what does that mean to you when you go to the doctor's office? Think of it as this sort of roadmap. Usually what happens is when you're ill, you've got a chronic health condition or a rare disease, you go to the doctor, they ask you questions about what's been going on recently, they look in your records at past history, and they look at your diagnosis. So what rare disease you have or condition that you have or predisposition you have and how that impacts your health now and how it might in the future. If you're going the precision medicine route, then the doctor might go one step forward and order genetic testing, whether it's a genome, an exome, or specific genetic testing, to learn if there's something different about your health that puts you in a group, and then they can precisely predict a little bit better how you might react to a treatment or how you might react to a particular monitoring schedule and what to watch for. When they do that genetic testing, sometimes when we look back there, their question is there anything within this test that supports a specific thing? Sometimes they're not going to find anything, but if they retest it, 5 years from now, they may find something. But at any rate, they're looking for something that could be useful to your care and putting you into a specific group. Then you move towards the discussion of options with the patient and family. You can move the slides back. We're still on that burden up. Discuss options with the patient and family and say, okay, when we looked at your genetic testing, we found that this particular change means that this particular therapy may be more effective. However, this is how strong that data is. Do you want to try this treatment or you want to try this other treatment? And usually your physician with precision medicine is going to help the family weigh these pluses and minuses. What makes more sense to try, which makes less sense? How strong is that information that you've learned from the genetics as compared to what's already out there? And then once you've tried a treatment path or monitoring schedule based on these changes that have been interpreted and then discussed and implemented, then how do you monitor that treatment? Just because one treatment seemed like it was going to be more effective based on a genetic piece of information doesn't mean we're not going to learn more information down the road. So you have to keep revising and paying attention to the specific care of that and therapy and monitoring and treatment for that condition. So you see how really it's personalized and precision medicine together, but the treatment is driven by these changes in the genetics and these genes that we can find, and what we've learned about that for particular groups of patients with that same change. Next slide, please. So how do we learn what we need to know about these gene changes? Well, in rare diseases, there is a big history of many patients advocating within groups, support groups, advocacy groups, to help learn as much information as possible, whether it's through natural history studies or clinical trials. These are all ways in which people have helped in the past learn about precision medicine. And in the rare disease community, this continues. Within precision medicine, the reason we've got as far as we have is because of all the communities and collaborating between patients, health professionals, pharmaceutical companies, and researchers, where we've found enough good, strong information to start dividing people into groups based on things that could help them more, or based on natural history and genetics. There's already a precedent in FDA approval of certain medications that say, you know, this didn't work for everybody with this condition, for example, Duchenne muscular dystrophy, but this can be approved because it worked for certain people. So you can see how precision medicine combined with genetics can then help the FDA understand why this medication might work in some people and not in others, and why it should be approved for the group that it works in, recognizing that we still need to go to work to help the other folks. Next slide, please. So when we think about barriers, something that we need to know is that genomes are not cheap, exomes are not cheap, and they're often not covered if you already have a diagnosis, or you don't have insurance, or your insurance just decides that is not going to be something that's medically necessary. So precision medicine that all relies on a lot of these genomes and exomes can be halted right away. Well, some people can pay out of pocket for genomes and exomes, but that's not everybody. And you need everybody's information if you're going to have strong precision medicine in a particular rare disease. So that's one of the things, access to testing. The other thing is that we still don't have enough good information about gene changes and how they might affect what is going on for a specific individual or group of individuals. This is because when we're looking at rare diseases, to slice and dice that rare disease population, even smaller populations, makes it hard to have a clinical trial that is strong enough to give enough proof for statistical significance, which is what things like the FDA and the pharmaceutical companies and scientists and doctors need to prove that something works, and it's not just a trend that we're seeing. It can also be a little bit more difficult to interest a pharmaceutical who's interested in, of course, at the end of the day, helping people get therapy, but also they would like a profit when they're done, and their shareholders would like them to have a profit too. It can be hard to interest them in a very small group of people. You know, if there's certain legislator that has helped pharmaceuticals in developing treatments for rare diseases, and they're looking at very small numbers. But now we're looking at even a smaller subset of people. So that can also be a barrier to precision medicine in rare diseases. Next slide, please. So in order to succeed, everybody needs to participate in rare diseases, because the more information we have, the more genetic information we have, the better things are going to be. And the more information we have, and the more ability we're going to have to work in these small subgroups that really help us understand what's the best therapy, the best monitoring, and the best game plan for a particular person with a rare condition. There are some things already out there that can help us with this. The NIH has funded a trial called All of Us, and that's not specifically for people with rare diseases. It's for, as it says, all of us. So that's people of all who have all different conditions, whether they've got diabetes or if they've got the rarest tumor. This is really trying to get a good, free genome as long as people are willing to give a little health information and help us understand the changes that they find. So this is an interesting program that everybody can check into. I did take it myself. I'm now in the All of Us database. The other thing to look at is many rare diseases have a registry, whether it's through their support and advocacy group, pharmaceutical company, or through NORD, or through Global Genes. These different ways to have registries where you learn more about individuals. These are important. With that information, we're able to learn more about conditions, natural history, and genetics. You can also, when someone's participating in a clinical trial, usually they're going to ask you if you're willing to provide additional blood for further testing, whether it's genetic or not, they should tell you. But these sub-studies help figure out different groups that could be used in precision medicine for the medication under study. There is precedent where there's been a drug that just didn't seem to be meeting the therapeutic endpoints or showing that it was particularly effective in a condition. But then when they were able to separate out into groups, they were able to see that a particular set definitely responded, while a different set of people within that same rare disease did not. So this is important when we look at clinical trials and participating in them. And then, as always, patient involvement and advocacy when it comes to designing rare disease studies and moving through the FDA process is critical, because without information about, hey, I find that this family has this particular set of conditions and this one over here is a little bit different, you can't, as a scientist or a physician, really understand the differences between different symptoms within a rare disease unless you have some help from people who are the true experts, the people living with the rare condition. Next slide, please. Personalized medicine is not quite where we would like it to be. If you read some of the articles, you might think that we're so close to just doing your genome and figuring out exactly what you need to get the best possible treatment for you and your rare disease. Like a bespoke suit, right? The doctor can measure you up, look at your genes, and give you the best possible medication for you. We're not there yet, so don't believe all the hype. Next slide, please. However, there are some really amazing success stories within the rare disease community and precision medicine. I've just put up a couple options here that range from, cancers to tumors to genetic conditions, all within the rare disease space, all which have managed to find some subgroups for precision medicine and 5 medications approved for that. And you're going to hear more about these success stories with the new case studies following this one. Next slide, please. So I hope that gave you a really nice introduction to precision medicine, how we think about precision medicine, and how not only can you envision how it will work in your life or your loved one's life as you face a rare condition, but also how you think about how you can help precision medicine improve. And then again, we'll have some really great examples coming up of cases where this really worked. Precision medicine has made a huge difference in a particular set of folks with a rare disease. Any questions? I'm willing to take now.
Well, thank you, Dawn. I want to remind our audience they can instant message questions as we go. Dawn, when we first talked about doing this webinar today, I was kind of surprised because I think of treatment of rare genetic disease almost by definition being precision medicine. How new a concept is this in the world of rare disease?
That's a really good question. When I think about rare diseases in our practice and what we do in daily life, where I work in a lysosomal storage disease center, it does feel like we're doing personalized medicine, that we are looking at one patient, trying to figure out the best path for them and move it forward. But I think that over the past 5 to 10 years, we've really moved more into the precision medicine approach. No longer are we saying you have this condition, you are an individual and nobody else is like you. We're going to do this particular approach just for you. We're saying, hey, based on these biomarkers, based on these things that have changed in your health history and based on your genetic information, it looks like you may fall into this group here of attenuated or more severe patients, and we should move forward in this way. I think a great example is in a rare genetic condition called mucopolysaccharidosis type 1. And we've learned so much about how that condition is on a spectrum from a very milder set of symptoms that still is life-impacting, but doesn't occur quite as early, all the way down to a very severe form of MPS type 1, where we would consider a bone marrow transplant or a hematopoietic stem cell transplant as soon as they're diagnosed, as opposed to other folks where we watch, learn, and treat them with enzyme replacement therapy, or some combination of those therapies. And I think it's all about dividing into groups, not for purposes of pointing out somebody's being milder or more severe, but more in the way of thinking about rare diseases as truly being made up of subgroups that can better benefit from particular therapies or monitoring schedules or ways that we can tailor things to, in some cases, maybe even do less monitoring as opposed to others where they need more. I think if we're looking at rapidly progressing versus slowly progressing, that can really help improve someone's quality of life. So if they're not at increased risk for a particular problem, we're not putting through all the different tests that you need to follow that. But we really need good, strong evidence before we stop doing our full body monitoring like we typically would do in rare disease with just a diagnosis as our guide.
in the broader world of medicine, it's the area of oncology that has really led the application of precision medicine approaches. Is that true in the world of rare disease as well? Are we seeing this primarily used in rare cancers?
This is an interesting question as well. I think when we think about rare diseases, there are definitely shining examples of precision medicine used in rare tumors or rare genetic conditions. But when I think about some of the FDA-approved medications, when I think about some of the great successes like in cystic fibrosis, these are really not cancer conditions. These are Mendelian, which just means they run in families in a specific pattern, genetic conditions that are rare but run through families. And I think some of the benefit to learning about precision medicine in these rare genetic conditions is that we have other family members that we can look at and say, oh, we've got a broader subset of information here. This will help us determine when something might be applicable to this small group of patients with this rare genetic condition. And I think Rob Hopkins' example in Fabry disease is going to do a nice job of showing how that's worked in several different genetic conditions that are not related to oncology.
Part of what I think is implied in the notion of precision medicine is that doctors have an arsenal of therapeutic options to draw from. As I think about the world of rare diseases, for those of which there are options, how much flexibility does a doctor have in terms of choices?
The choices are still fairly limited in rare diseases. It's becoming more and more as we go through the years. And I think over the past 5 years, there's really been an explosion in interest in developing alternative therapies for conditions. And also as patents run out, there's some lockdown, you might say, if there's a particular patent that's to a particular company for a particular therapy for one rare disease. But as patent runs out, there's more incentive for pharmaceutical companies to really look at what's out there, what scientists have learned, what therapies they've been bringing up that are not yet marketed. So I feel that more options are coming, but it's true, things can be limited at this point when it comes to broader therapies that go to the root of the problem.
You talked about genetic testing a lot. What role do other biomarkers play in precision medicine?
Yeah, depending on the condition, you can have very strong biomarkers that are related to imaging, or you could look at those that are related to particular issues within the body. So, for example, a rare condition that's related to the heart may have a marker like a BNP or a troponin that they can look at to look at the risk for heart failure or decreased heart function. Those are definitely things that play into it. And precision medicine, genetic testing is a large part, but not the only part. Because without the other biomarkers, the other health symptoms you learn about, without the natural history, you don't have anything to focus on for that genetic testing result and how it might impact things. So it really is looking at all aspects of an individual's metabolism, which is how their body works and how they function and what they produce as their body's working, and any signals that tell us this person is going to do better in this aspect of their care or one that might do less. So we're trying to predict the future a little bit with precision medicine. And the only way to do that is by having a lot of good information, ranging from the genetic information all the way to those biomarkers. And when we find something in one particular rare disease that tells us about heart function or kidney function, that's when we should look across rare diseases, because there might be a clue from another condition that's going to help precision medicine develop better therapies. For example, inflammation. Many rare diseases have issues with inflammation. And if you treat inflammation in one disease, like polycystic kidney disease, it might work well in another disease. And so I think that precision medicine in rare conditions opens the door for other rare diseases and actually can help us focus on common conditions as well, like diabetes or hypertension. So we learn from each other, and there's a lot of interplay. And I think that just underlines the need for collaboration between everybody involved in the treatment and therapy and care of patients with rare diseases.
Well, let's turn now to our two case studies. The first is in a lysosomal storage disorder. The second is in a rare cancer. With that, let me turn it over to Robert Hopkin, Associate Professor of Clinical Pediatrics of the Cincinnati Children's Hospital Medical Center. Robert?
Hi. I'm very happy to be here. This is a topic that I am quite passionate about. Can I get the next slide? Okay, we're going to be talking about a case that I have been involved with for a long time. So this patient was born as a newborn, was noted to have excessive fluid surrounding the brain and in the ventricles of the brain. Also had a connection between the esophagus, which is the tube that you swallow food down, and the trachea, which is the tube that goes into your lungs. In addition to that, at the top of those two tubes was a laryngeal cleft or a slice of sorts that connected those two tubes for a longer distance. There was a major blood vessel coming out of the heart that compressed the trachea, and some of the ribs were fused. Some of the vertebral bodies were abnormal. In short, there were a lot of problems. And she required a number of surgeries as a newborn, and then throughout the next several years. So on the slide, I list 4 different areas that needed surgeries, but each of those things needed to be revised at least 1 or 2 times. She had a large number of medical procedures. At the time that she was born, the testing was not developed the way it is now. So we looked at her, spent a lot of time in the library trying to find a diagnosis or other cases that had similar problems. And we were having a hard time, so we did the best we could with what we had, but did not make a specific diagnosis. Next slide. So over time, she was noted to have a number of medical complications. Her bladder didn't work very well, so it didn't squeeze the way it's supposed to empty. Her pancreas got focal inflammation, which caused abdominal pain and digestive problems. With the hydrocephalus, most people will have some degree of developmental disability, and she had that, although it was relatively mild. As a result of some of the procedures she had, she developed a vocal cord paralysis. And with all of these procedures and hospitalizations and other problems, she had some behavioral issues related to the trauma just from the care that she needed. And she developed severe chronic headaches on top of that. Next slide. So the initial testing that we did when she was young was a test called chromosomal analysis, where we just look at the chromosomes under a microscope, and you can tell which chromosome is which by size and by patterns that they have in light and dark colored bands. We looked at that, and everything looked normal. Now, that did not by any means mean that there wasn't a problem, just that at that time the testing that we had was inadequate to identify what the cause was. Sometime later, a new technology came along called a SNP microarray. So SNPs are single nucleotide variability in the gene. So of the letters in our DNA, a SNP is where one of those letters is variable, and that's a normal finding. And certain percentages of the population will have different letters at that site. And the testing that we did with that microarray looks to see if there are any whole genes missing or duplicated. It does not read through the genes for spelling errors as small as one letter. And so we did that, but we noticed something that wasn't a deletion or a duplication, which was what we were looking for. But we noticed on chromosome 3 there was a region where there was no variability. and we didn't know quite what that meant. And so we went and looked up what genes were in that region. We didn't find anything that really fit with her problems, and we still didn't have an answer. So more recently, she is now at 19 years of age. She has done fairly well in spite of all of the medical issues and the worry and things that she and her family have been through. She's now a young adult. She has a boyfriend, and there's still not a specific diagnosis. So she comes back with her family and her boyfriend, and we talk about what she's got and what risks we might need to address. And one of the things that we talk about is the changes in the genetic technology. So there is now the ability to sequence, instead of one gene at a time, with a very high cost per gene, we can now sequence dozens or hundreds or even thousands of genes at a time without greatly increasing the cost or the turnaround time. And that technology is relatively new, but is now being widely used for certain indications. And this is the kind of a case where that technology is thought to be highly valuable when you know that there's a problem, you think that it's genetic, but you're not sure sort of what your specific target is. It doesn't fit any of the patterns that are familiar that you can look up, so you can't pick a single gene or a single diagnosis to test for. You need to look more broadly and just say, what is there? So what we proposed was doing something called a whole genome or a whole exome test that sequences the coding portion of all of the genes. And that was the picture of the slice out of the apple that Don showed. It's that slice, which is 1% of our genetic material, but that's where 90% of the problems at least the ones we've discovered so far, with our genes occur. Next slide. So at this point, I want you to think about these questions. What do we know about this young woman and her risks? What do we need to know? And is there a reason to do additional testing? So I already kind of gave away the last one. There is some additional testing. So what do we know? We know that she had multiple birth defects, that several of them are potentially life-threatening, and that she has had to deal with multiple complications of those birth defects throughout her life. What do we need to know? Well, we would like to be able to predict what kinds of problems she will have in the future and how we will deal with those problems. And we would like to know what is the chance, if she gets pregnant, that her children could inherit problems similar to what she has. And so there is a reason to do testing. It's to try to get those answers and then use them to give her best health care. Next. So our testing options at this point are single gene tests where you pick one, you look at the pattern and you say, gee, this is this symptom and that symptom and that symptom, this could be, and you name a condition. And you have a pretty good idea what it is. So if somebody comes in with a fever and pain in their right ear and having muffled hearing on that side compared to the other, and maybe some nasal congestion, you have a pretty good idea that they're going to have an ear infection. Then the doctor looks at that eardrum and says, yep, there is an ear infection, or no, there's not. If there is, then you treat it. So single gene testing is like that. You pick something, you pick the right gene, and you recognize the pattern. But I've already mentioned in this case we didn't have a pattern that we could recognize. We had some very serious birth defects and reason to think that it's genetic, but not a recognizable pattern. The next thing that you can do is pick a panel where there is a family of disorders. So you could say, okay, we're going to pick genetic conditions associated with hydrocephalus, and we will test for all of the known genetic causes of hydrocephalus, and then we will call that good on the evaluation, and hopefully we will find an answer. The challenge in this case with that approach is that we could do a panel for hydrocephalus or brain malformations. We could do a panel for heart defects. We could do a panel for airway malformations. And each of those things would involve a fairly high amount of processing and some complex evaluation. And if you do all three of those things, then that would cost more than just looking at all of the genes at once, which is what the last option here is just if we don't have a good idea where the focus should be, but we do think that there is an important question and a high chance of finding a genetic cause, then there are times when we can just say, just sequence everything, and we'll look at it and see if we can find the answer. Now, there are some challenges with that. There are 3 billion letters in the DNA that most humans have. And there's a lot of variability in that. No two people have exactly the same sequence of letters. So knowing which variability is normal and which variability needs some attention is a challenge. But this testing has been done enough times now that we're starting to have a pretty good idea of what's normal and what's not, and which things to pay attention to, and which are probably normal variability. Next. So in this case, we opted for the whole exome test, and this is what the results said to us. So things related to probable disease-causing variants, meaning things that relate to this patient's phenotype. You'll notice the first red line there says no variants found in this category. So we did not find on this test an answer to why all the birth defects happened. And for me, as the doctor taking care of her, that's a little frustrating, but that it happens. We aren't to a point where we are going to know the answer every time on every case. The other things that we look at in genetic testing are there any things that might be related but aren't necessarily? And that's what the second category is, additional variants of interest. So you will see that there's a gene called CHD7 mentioned on there. And CHD7 is associated with heart defects and breathing problems and feeding problems and intestinal problems, but not with hydrocephalus and not with laryngeal cleft, which are two of her biggest problems. But this particular change in CHD7 is of unknown significance. It's not been reported before in any people. So we don't know quite what to do with that one. And then the last one here, additional medically actionable findings. This means a change in a gene that we think will impact health, but that is unrelated to the reason we did the test. Now, before we run the test, we counsel families, explain this testing to them, tell them what we're going to do, what kind of information we can get, and we talk to them about these three categories of changes. And then we give them some choices. Nobody's going to come in and say, I want you to run this test, but I don't want you to tell me the things that are related to the reason you're doing the test. So that one, it's pretty much a given that everybody wants that information. But the last two, additional variants of interest that may or may not be important to the reason we're doing the testing, and things that are medically important but that are not related to the reason we did the test. Some people want those and some people don't. Okay, next. So, who understands exactly what to do now and what to tell this family? So I am hoping that nobody does, because when I got these results back, I did not know exactly what I was going to do, so I went and looked up each of these changes, and I looked through the data for the whole exome test and came up with a plan. Okay, next. So the key points on the testing so far: no diagnosis for the birth defects that drove the testing. The CHD7 mutation in this case was inherited from the patient's mother. Patient's mother has no chronic health problems, is normally functional in every way, and has the same thing. This is very important because that means that probably is not causing a problem. So we concluded that that particular change is probably a benign variant and won't cause any problems, and we opted to then ignore that one. The other variant that we found, the GLA variant, was inherited from her father. Now, there are several different patterns of inheritance that genes can have and how they impact health. This one, the GLA gene, is on the X chromosome, which means men only have one copy of it. And that's important because that means men are at higher risk than women. The other thing that's important about this variant is it has been associated with a disease, but that disease, even in men, this particular change in the gene, even in men, causes a relatively late onset condition that can result in heart failure, kidney failure, and or stroke. And those are pretty serious things. The risk is higher for men than women, so we need to know the status of her father. Her father reports feeling healthy, but has never been evaluated to see if he has heart disease. He's never had a stroke, and he hasn't had any recent testing to look at kidney function. Next. So what do we do now? So a couple of things that we did. For the patient, we needed to evaluate her and see if she had any signs of kidney disease, heart disease, or stroke. That's very difficult in this case because she has had surgical changes or surgical interventions on her heart and her brain. So she has abnormalities in the heart and the brain, and she has some kidney abnormalities that are secondary to her bladder not emptying completely. And those are related to the birth defects, but they could be masking issues related to the problems caused by the change in the GLA gene, because those could be quite subtle in a young adult. Now, is this important for her father? Since the age of onset for major complications for the GLA-related disease, which is called Fabry disease, with this particular change is around age 50, most frequently presenting with heart disease, and it becomes detectable around age 50 but won't necessarily interfere with your daily function at that age. He needed an evaluation as well. Next. So Fabry disease comes in two categories. The classical one is pretty easy to recognize, typically early onset with first symptoms in childhood, and life expectancy for men is around 50 years. For women, it's a little bit longer than that. The first symptoms they have are pain and or chronic diarrhea or chronic abdominal pain, and then slowly over time develop kidney disease, heart disease, and have a very high risk for strokes and possibly some other problems. This family doesn't present with that, but the genetic change in this case is a subgroup of Fabry called non-classical, and in that you can have variable onset of symptoms from early adulthood into old age, and often they will present with only one system of the body, so only the heart having dysfunction or only the kidneys having dysfunction. And both the patient that came to see us initially and her father are still young enough that we would not expect them to necessarily have major health problems related to it at this time. Next. Okay, so what did we do? So the father, we did some blood testing looking at biomarkers to see if he had evidence of Fabry disease. And he did have, on a blood test, some evidence of active disease. So we then got a pretty thorough evaluation of his overall health with eye exam, echocardiogram, to look at his heart function, and some testing to look for kidney disease. The daughter has a lot of health problems. With the mutation, many women will not become ill, but some will. However, she's 19 years old, and the symptoms for women with this particular mutation would be in the 50s, 60s, or 70s, typically. And so for her, we did all of the same baseline evaluations, and we were fortunate in not finding anything that wasn't directly related to the known birth defects. So for her, the plan at this point was to monitor her over time. She did not require an immediate intervention for the Fabry disease, and there is some chance that she never will. But if she has children, she could pass this change on, and particularly if she has sons, they would be at risk to develop signs or symptoms of Fabry disease. Next. So for the father, we opted to, because he had evidence of disease, he was interested in prevention because he's a very active man. And he wants to maintain his level of activity, and he was worried that we were going to give him restrictions on his lifestyle. And we said, no, that's not our goal at all. What we want to do is help you to preserve the good quality of life that you have. So we had a couple of options for treatment. There is a new medication that's an oral medication, just been approved for not even a year, but it's available. And there's an established medication that's an IV medicine that you get an infusion every 2 weeks. So we had to choose which one of those was best for him. So how do we do that? Well, we have to ask him lots of questions. So we asked him time constraints, health problems, and then we go through the pros and cons of each of the medicines, how much data we have, how compelling is this. And in his case, the time constraint issue was the most limiting factor on pursuing treatment. So he opted to take the relatively new oral medication, which is something that you would take one pill every other day, and you just do that, and then we monitor him, his heart and his kidneys and his general health pretty closely. So that's the plan for him. For his daughter, we're going to do the monitoring but not do any intervention at this time. So the take-home points here are we do have many new powerful tools for making genetic diagnosis. Even the best tools sometimes don't give us all the answers we want. We did not get the answer to the main reason we initiated the testing in this family. We may find unexpected risks or unexpected results that were important, which we did in this family. One of the things that I think is important is that families can manage this kind of uncertainty if we prepare them for it ahead of time and we explain it to them and we take their questions. Most people can manage this well. In this case, obviously they were shocked initially, but the family has adjusted well, and we are now able to do some things to preserve health and to intervene on behalf of the family prior to any major health problems developing, which I think will be of great benefit to them in the future. Next. So additional things, considering the details in the context of the patient's life is an important factor in making the decisions, making the right choices. Different management decisions can sometimes be used appropriately even for the same diagnosis, even in the same family with the same diagnosis. And sometimes we need to consult with other experts and call people in, and that's especially true for rare or very rare conditions. But it's also true for extreme examples, either extremely mild or extremely severe examples of more common diseases. Next. Okay, any questions?
Well, actually, we're going to save questions for the end because of time constraints right now and move straight ahead to our final case, which looks at acute myeloid leukemia driven by a specific mutation. I'll turn it over now to Torsten Haferlach of the Munich Leukemia Laboratory. Torsten?
Yes. Hello, everyone. And good morning or good afternoon. I'm right now on the Congress of the European Hematology Association in Amsterdam, so for me it's 8 p.m. And I'm very happy to be part of this webinar, and I'm very thankful also to Dawn and to Rob, who gave brilliant talks that really outlined a lot of background that also is needed, and I will refer to in my talk if I'm going to talk about a specific rare case of acute myeloid leukemia with, in addition, a rare and specific mutation called FLT3. So what is rare in a case of acute myeloid leukemia? Just to give you an idea, the incidence to suffer from a disease like acute myeloid leukemia, AML, is 2 in 100,000 inhabitants per year. So it's a rare disease. And the symptoms sometimes are very bad. This is one of the reasons to call this disease acute in comparison to chronic leukemias. It's one of the acute leukemias. But sometimes patients are diagnosed with a little time where they just felt a little bad. This was a case with a patient of 62 years old, visited his general practitioner, and he had some fatigue and fever. And as normal in these circumstances, there is blood drawn. And what was quite clear after some hours is that the white blood cells, the leukocytes, were elevated. They were increased to 50 giga per liter. Normal is 4 to 10. So that's quite high, quite clear that this means something. And the hemoglobin was decreased to 9. Normal is 12 to 16. That explains a little bit the fatigue from this patient because there was not enough erythrocytes to take care for the normal O2 delivery in the body, and then the platelets that take care and need to take care that you have no bleedings, they were also decreased to 80, normal 150 to 350. So with these three changes only, and with the patient's symptoms, one can speculate that there may be a specific disease, leukemia. You cannot say from this blood count it's an acute leukemia. You just have the idea maybe a leukemia, and at that moment, specialists like hematologists and oncologists taking over, and this was the case in this patient as well. So he was referred to more in-depth investigations of these findings, of these abnormal findings of the blood. And normally not only blood is only analyzed, but also a bone marrow biopsy is taken and investigated. And the investigations are shown on the bottom. So you look into the microscope and you see these abnormal cells. They are called blood cells. Then you have this cube where you can investigate with all the cells from the blood or the bone marrow with some specific antibodies. And these antibodies are linked to the surface of the respective cells that you investigate. And depending on the composition of the white blood cells, you get a specific pattern of normal or abnormal cells, leading you to the diagnosis of the respective leukemia. And in addition, that already was explained from Rob, you do a chromosomal banding analysis where you see all these chromosomes there in the mitosis. So we have 46 chromosomes normal, pairs from 1 to 22, and XX for a woman and XY for a man. And with an increasing need to be investigated, and this was also very nicely explained by Dawn and by Rob, we are investigating genes. It was some genes some years ago. Now it's more and more genes. So we normally apply a panel that was also introduced before with up to 60, even 100 or 500 genes to be investigated for this respective disease that was diagnosed before by the phenotype, that means the morphology of the blood or bone marrow smears, the immunophenotype, and the chromosomes, in addition, these genes. So what came out for this patient was that the diagnosis is an acute myeloid leukemia. He has a normal karyotype, no chromosomal findings, but we found out that there is a mutation in this specific gene that is FLT3. We have two different changes in that gene. The one is called internal tandem duplication, it's ITD, and the other one that he hasn't is called tyrosine kinase, and this is FLT3 TKD. And another gene that is also going along with mutation of FLT3 is NPM1. It's very often also mutated. This means something for the patient, his diagnosis, his treatment, and his prognosis, but in this case it wasn't. So we finally found out that this patient has an AML with a FLT3 ITD mutation, and he was referred to a specific clinic to start the treatment that needs to be started quite soon after the diagnosis because it's a real malignant disease. And the goal, and this is very important for those patients with AML, is to cure the patient. And the question is, how could this be done best? So the next slide gives you, and I will not go in any of these details, already the actual and revised WHO classification for AML. And if you look here, you see many, many chromosomes, you see many, many genes, and you see the composition of chromosomes and genes. That means we are not speaking about the AMLs, we speak about one AML within the broad spectrum of AMLs. So if AML is a rare disease, the respective patient's disease, if you split them up in all the needed options based on their chromosomal changes and the molecular changes, they are really rare diseases. And there are for sure some patients that have the same AML than the others. But if we look closer and closer, and now are also on the way to add exomes and genomes as demonstrated in the other two talks, we will finally end up with a very specific AML per patient. That does not mean that these findings right now have specific treatment options, but there are some findings, and FLT3 is one of these findings, that offer specific treatment options. And this is not only offering specific treatment options, but, next slide, it means something for the prognosis. And this is the prognostic schema we use right now from the European Leukemia Net, published 2 years ago. And you will find a lot of these genetic or molecular genetic changes from the WHO classification also here. But this table does not show the classification diagnosis that the disease has to follow, but it demonstrates the risk category of the respective AMLs, subdividing into favorable, intermediate, or adverse. And if you look into the adverse field, you would see, for example, that wild type, so no change in NPM1, but FLT3 ITD mutated with a high ratio, this is adverse, this is bad. If you look into the intermediate part and you see patients with a normal karyotype and the NPM1 is not mutated, but FLT3 ITD is mutated, it can go there if it's low expressed. So it's really getting complicated. And as doctors have to learn this, to do the correct steps for the patient, you can imagine that, and we learned this from Rob as well as from Dawn, it's quite difficult to explain what we want to do, what we want to investigate, what the findings are we have, and what does this mean for the respective patient. And just to compare this to the other case we learned from Rob, here we have only 1 or 2 days to tell what is going on and what we have to do. So the precision medicine approach needs to be applied quite quickly. There is no time to think about it a day or a week or a month. We have to start with the treatment and with the correct treatment. And next slide. There are several very specific treatments. So again, this is a landscape of chromosomal or molecular changes in AML, what you see here. And there are some drugs that target specific structures. And if you look here on FLT3 and you see these 4 drugs in red, there are some of these drugs have already been applied now and accepted from the FDA to be used in AML when the FOT3 gene is mutated. And that means precision medicine. You diagnose the patient, you look into this specific molecular and genetic background in these AML patients, and then you look for those drugs that can be used already because they are FDA approved. And FOT3 has some drugs FDA approved. And the next slide demonstrates that there are several SLT3 inhibitors. And this is a slide where some of these drugs still had some generic names from the companies. And the PKC412 is now midostaurin. We will come to this later. And for example, AC220 is now crizotinib. That is also now useful and FDA approved for relapses of AML. So, and what we see here is an interaction map of kinases where these small molecules that directly work against the defect in the leukemia cell, here SLT3, where they directly interact. And you can see that there are some drugs that address a lot of structures in these three, and some that are more specific. And this is very interesting and important because if you are going for more specific approaches, you may hopefully also have less side effects. So the next slide now shows you how often this is, and this is data from our laboratory. And you can see here that in nearly 4,000 AMLs, we found around 10 plus 8, so 20% of cases that demonstrate this mutation. So every fifth of this patient, 20%, shows this mutation and can be treated with precision medicine drug like midostaurin. And the next slide shows you the very important thing is that this is a diagnosis, but when the patient has a remission and that is very sad, has a relapse maybe some months or years later, he can change this profile. He can go from FLT3 mutated to not mutated anymore, or the other way around. So that means you have to test it also at relapse, because even if this structure to be used in precision medicine was not found at diagnosis, it can be changed and mutated at relapse, and that offers you other treatment options at relapse. Next slide. The same is true for FOT3 TKD. It is around 5 to 10%, so all over we have 30% of AMLs with this FOT3 mutation. And again here, from first diagnosis and relapse, there may be a shift without or with this mutation. So this is very important for any treatment in this disease. And the next slide now shows you the updated 5 weeks ago updated guidelines from the NCCN that we and others follow to treat these diseases. This is now for the patients above the age of 60, but the same is more or less true for patients below the age of 60. And what is quite clear, and I highlighted that in red, is for this patient, 62 years old, with an intermediate risk, a normal karyotype, and an FOT3 mutation, the standard chemotherapy needs to be always combined with these new precision medicine drugs, this oral midostaurin, at first diagnosis. And as I said before, other FLT3 inhibitors can be used also in the situation of relapse. And this is now standard of care, but first of all, you have to test, and then you go for this specific treatment. Next slide. Now, what is always important in the US as well as in Europe and other countries is what specific drugs we have can be used as a targeted drug, and what are the side effects, And do we have an approval? Do we have an FDA approval? Do we have an approval in Europe? It's called EMA. And in what situation you can use the drug? Because it is not always paid from the healthcare system for every patient. If you don't have the approval, you may ask your insurance company to get that, but it's quite easier if you see it. It is approved, and then you can use it and you follow just the guidelines that have been published. And as has been outlined by Rob as well, we have to talk to the patients about the side effects and the problem he or she has with other problems like heart diseases, where you have to check the electrocardiogram, or GI toxicity, where you have vomiting or nausea or diarrhea. So this has also be taken into account before you start with the treatment. And the next slide is my conclusion already. So although AML is a rare disease, it's even more rare if you look into the respective background from the chromosomes and more on the molecular background. And you need both these information at diagnosis as quick as possible with a very short turnaround time. You have to discuss the result with the patient. And you may start, and you will start more and more based on these findings with specific treatments, because this will increase your cure rate and will decrease your side effects. And this is what we all intend, to have more targeted treatment options, getting away from the standard chemotherapy that in the way we use it right now, we use it now since nearly 40 years. And these drugs that work against FLT3 were the first drugs that came to the treatment of AML after 20 years of no new drugs in 2017. This is also important with respect to any other treatment strategy. For example, bone marrow transplantation. If you want to avoid the side effects of bone marrow transplantation, you may think even more about targeted treatment, and treatment response can be measured, called minimal residual disease. And what I also said before, if the patient suffers from a relapse, this diagnostic approaches have to start again, because you may have a change in the pattern of the leukemia cells at that time point that opens options for another, or at that time point from the first diagnosis not available, specific, personalized precision medicine drugs. Because in AML, we always try to go for cure. The cure rate depends on the patient himself and on the genetic and molecular genetic background, and we have to be very flexible to do the best at all the different time points. And this is what I would like to tell you about a rare disease like AML.
Well, thank you very much. We're basically out of time here, but I just want to ask our panelists very quickly whether there are things patients should be doing, tests they should be requesting, or questions they should be asking to ensure they're getting a precision medicine approach. Dawn?
When I think about what patients should be doing, I think it's important to stay closely connected with their support and advocacy group. And because often the support and advocacy group is on top of new therapies as they come down, and they also are usually pretty good about telling people what monitoring is important. And then feeling comfortable with taking their monitoring schedule they learn about the support and advocacy group, and just asking the physician, is there anything different we should be doing, any tests we should be adding or tests we could take away based on what they've found from their interactions with the patient and advocacy group, because using those pieces can then help develop a precision medicine approach.
Well, I want to thank our panelists so much. I have many more questions for all of you, but I've got to wrap now. Thank you, Dawn Laney, Assistant Professor of Genetic Counselor and Genetic Counselor at the Emory School of Medicine, Robert Hopkin, Associate Professor of Clinical Pediatrics of the Cincinnati Children's Hospital Medical Center, and Torsten Haferlock, of the Munich Leukemia Laboratory. Thank you all for joining us today. I'd also like to thank our sponsors, Amicus Therapeutics, for their support for today's webinar, and Daiichi Sankyo, and the staff of Global Genes and Ashley Yee for her work putting together and coordinating today's program. One reminder, the Rare Patient Advocacy Summit will be held in San Diego September 18th through September 20th. You can find more information on the Global Genes site. On behalf of Global Genes, I'm Daniel Levine. Thank you all for joining us today.